after a hip arthroscopy. But if we are treating femoroacetabular impingement, and there are two things that I think that are very important. One is that the patient with femoroacetabular impingement usually has a lag in the force of the gluteus medius. So there is a disbalance between the abductors and adductors in the hip, and that must be corrected. If you want, even in the preoperatively, you can begin with force in the gluteus medius. But especially in the postoperative, you must take care of accompanying that balance between gluteus and adductors. The other thing that is very important in the postoperative of femoroacetabular impingement is to avoid excessive isometrics of the psoas. The physiotherapists usually do a lot of isometrics of psoas. They like to do that in order to have a strength in the psoas muscle. But after a femoroacetabular impingement surgery, it can be worse because the patient with femoroacetabular impingement has, after the surgery, has more internal rotation than he used to have. So there is a more opportunity to the psoas tendon to compress with the capsula that has been just repaired. So I think it's important to be very gentle with the psoas in order to avoid psoitis that are prevalent. And the rest of the protocol must be depending on what you have done. When I do lateral reconstruction, I always try to avoid more than 90 degrees of flexion and more than 20 degrees of internal and external rotation during the first 3 weeks in order to not compress that labrum just referred. But they need to move from the first day in order to avoid the adhesions between the labrum and the capsula. So you must play between movement but not too much in order to avoid detachment of that just referred lesion. For the quadral lesions, it's what I explained. I think that you have to do, as Hassan said, I think it's the non-weight bearing is useless in the hip. I think it's better to do two that weight bearing. Another thing that you can do is to put a bigger, high shoe in the other side in order to have the limb completely floppy. But this is very difficult, the patients don't understand, so I think it's better to go with partial gluteus wearing. And I do that, as he said, for the first 6 weeks, 6 to 8 weeks, in order to protect that just repaired cartilage lesions. I'm not worried about fracture of the femoral neck, and so if there is no chondral lesion, I accept complete weight bearing from the first day postoperative. So the only reason to do just weight bearing is chondral pathology, otherwise complete or full weight bearing from the first day, assisted with crutches during the first 2 or 3 weeks in order to make it more easy. But I'm not worried about fractures of the femoral neck. And that's it.
Yeah.
That's it.
Okay, the final plan. I've taken out 3 of my talks. I'll give you 2. One is peripheral access, because we've had some requests on the basics again. Some people are saying we went through the basics early. Plus, people are going to go into the workshop again. So just revise that peripheral way you do the technique. And then the last one is the complications, which is very important. The talk about labral repair, I think you've seen enough to cover most of it, so we don't need to go through that. So peripheral access, as you know now, the central compartment. There's the central compartment, there is the finger laser out. There's the central compartment, which is covered under the sternum, peripheral compartment, and extra-articular, which we had the last surgery on. So we've done surgery in the 3 compartments. Now, of course, it's difficult. I mean, you saw how to do a nice central compartment, but it is much more difficult in my hands, at least. I think when you become experienced, we saw Mark and Ahmed do it in a very nice way. But early on, especially if you're starting without supervision of an experienced surgeon, that is the main problem. You're starting in a new center alone. The preference is much easier for myself. It's a much bigger space. It is safer. It is safer for you when you're entering, less risk of structural injuries, damage to the injuries, and also it lessens your traction time, so the complications of tractions are much less. Okay? But when we did a poll during our last webinar, we found that still 75% of the surgeons doing central first and only 25% do peripheral first. So we do the peripheral access as you saw yesterday. Then we do capsular thinning, not a capsulotomy. Then we do the peripheral compartment work, and then we go on to the central compartment with the traction. Now, to remind you what we do, we mark the greater trochanter. We mark the anterior superior spine, line downwards, line upwards, they meet in one point. This point is our target. And this is how we do injection technique, and we've also published it as an injection technique. We use the Dean's portal, which is 2/3, 1/3 the distance, and we are targeting this point. Okay? And we go 30 degrees posterior. That is the injection technique, and that's the proximal anterolateral portal. So the distal anterolateral portal is about here, and the proximal anterolateral or the Dean's portal is here. But once we do work on the central compartment, it's always through this. This is easier to go into the central compartment. So we use 3 portals in this technique, but start peripheral and then move on to the central. So this is how we do the proximal anterolateral. We do a curve, and our distal anterolateral is anywhere along the curve. The more you're going to work in the low clock, then it's a lower portal. The more you're going to work in the anterior clocks, then it's a higher portal. You don't want to get too close because that will affect your camera. So this is the direction of the proximal anterolateral. This is the direction if you want to inject your hip in clinic without C-arm, without anything. You do the landmarks, you go 30 degrees posterior, you hit the bone, and you can inject it inside the hip. And then the distal anterolateral is almost perpendicular to the skin, very slightly headed kephalat. Okay, it's almost perpendicular to the skin with the landmarks we spoke about. So you saw this yesterday. You go with the distal, we flex the hip, we hit the bone, and you just slide above the femur, and you're inside the femoral neck. So no structures at risk here. No cartilage, nothing. It's quite safe. This is the safest. And I've changed from starting with this one to this one because it became, in obese patients, it's difficult to do the proximal anterolateral. So I start now with the distal, followed by the proximal. Especially that I'm not using C-arm. Maybe the C-arm, they're both as easy. You've seen how we go inside, so I'm not going to go through that again. And then the proximal anterolateral is the Dean's. And again, we do it blind. There's no C-arm. We don't have that. We borrowed it for the course actually. So you feel that I'm on the bone. So once I'm on the bone, I can inject. I'm already in the hip. Okay? But you just slide anterior to that. Once you slide, you're inside the hip. That's your proximal anterolateral portal. Okay? And you can see the back flow of water right away. It just confirms that we're inside the hip. And then you do the normal dilatation techniques. And this is the video. You're looking from the distal, you're looking proximal, and how the needle comes in. As soon as you create your second portal, the view improves a lot. So it's important to try early to do that. And flexing the hip, so you're not worried about cartilage damage here, even if you do that, because that area you will excise anyway with your cam. In the flexed position, not if you're in extended position. So again, it's an arthroscopy technique, it's 3-axis, open axis. It's this technique, we published it last year. And then we do the classic, we should do a Dean's tour. You start around the labrum, you go all the way to the medial synovial fold, the neck, and the lateral synovial fold. You do it in any sequence, but you should make a plan to go all around the peripheral compartment. So taking care, these are the tricks when you're starting peripheral. First of all, we work in about 30-40 degrees of flexion to relax the anterior capsule. Very important, you make the space much bigger. Again, next, it is a capsular thinning, not a capsulotomy. Although actually Michael Deese himself, he says he's doing capsulotomy, he's not doing capsulotomy. I told him, you are doing capsular thinning. We don't do capsulotomy because we want the balloon effect of the water while we're working in the peripheral compartment. The capsulotomy is only done when we're going central. We alternate, as you saw. We go through the peripheral, anterolateral, we switch back and forth to view the cam from multiple views, and I want you to do that in the workshop. I want you to have a look, all angles, and then switch the camera to the other side, and again have a look from all sides. So don't forget the around the curve principle. We saw that in yesterday's case, the cam. Again in the pincer, we saw that at the end of the case, we had to see around the curve to make sure we've taken away all the bone. And you can still work on the pincer itself while in the peripheral compartment without any traction, just increasing the flexion a lot. Once you increase the flexion, your instruments can easily reach the pincer and you can work on the acetabular edge. And at last, we extend, we use the portals to reach the lateral cam followed by the central compartment. So the capsule, again, it's a capsular thinning, not a capsulotomy. We only do the capsulotomy in two scenarios. If you're going into the central compartment, or as we saw yesterday, when there's a large lateral cam. That lateral cam we don't see in the flex position. It shows up at the end when we extend the hip. That lateral cam we need to go down a little bit. Sometimes you do a little bit of capsulotomy to be able to get around the neck of the feet. So this is the time that we do the capsulotomy. So this is just a case also, it's a similar cam to the case we had yesterday. You saw the capsular thinning. The radio frequency is very useful. Then we proceed with the burring. You again saw that, so I'm not going to waste your time with the videos. But again, we tried to do a sequence. Mark showed us a very nice way. He did a very smooth, gentle way yesterday. I was very impressed with that. And then until you see, you think you've done enough. So we're looking from the proximal anterolateral. We're working from the distal anterolateral. It looks very nice. You've established the head-neck offset. However, don't forget the pitfall that we're working in flexion and we are looking from superior. So we are missing here something we cannot see. You will not be able to see it unless you extend the hip and go downwards posterior with your portals. That's the only pitfall in the peripheral technique. So this initially looks fine, but it is not. I'll show you how. Look, after we extend it, you can see how much bone is still there. It's a lot of bone still there. So once you extend, you go down, we can see now, and then we take care of this part of the cam. Okay? And then you want to see a global view all around. You want to see the distal part, you want to see the proximal part. You want to do the testing in more flexion, in extension, just like we saw in all the cases yesterday and today. You extend and you see how much there is impingement or labral affection. So once we go on to the central compartment, we do the traction, we do the extra portal. So here I've used those. I wanted to work more distal. Didn't use the actual skin. I even created another one. You can still do that. You can use the same skin incision or use a different skin incision. Just you have to reach where you are and do what you plan to do. And again, the central compartment axis is under vision. So you see what's happening. In this case, he had a labral tear, he had a cartilage flap right there in front of us. So under image it might have been difficult to go in without injuring the labrum because it's very floppy. So you do the gradual traction, we can see it under vision and gradually enter the hip. So I'm looking from the distal anterolateral, I'm going through here through the anterolateral portal. So lastly, as a summary, it is easier. I converted definitely from central to peripheral because it's much easier. Bigger space, you can do the cam, you can do your acetabular recession, all that without traction. So yesterday's case, our traction time was 45 minutes. We did the cam, the pincer, some recession, and the 2 labral anchors. So it reduces your traction time greatly. Especially if you're a beginner, this is more important because your traction time will be much longer. So reducing it should be a major part in your planning. And minimal or no C-arm depending on how you have it. large cam, you might have no access to the central compartment, especially in pincer deformities, and then finally you move on to the central compartment. Okay? Thank you very much. This was the talk about peripheral access. Is there any questions? Mahmoud?
It's a comment also and a question, because when we were explaining the anatomy of the portals, some might get confused between the distal anterolateral portal, which is typically described perhaps in relation to the anterolateral portal, which is described 5 cm below and distal, and the anterolateral portal, which is distal in relation to the denum. So I want you to comment on that and also to clarify to the audience. So
okay, so I think the naming,
it's just I think some of you might have got confused. Yeah, I think so.
So let me go back to the slide.
Yes.
This might be good. So I think that there's some overlap of the namings, to be honest.
Yeah.
First of all, the one here is we call so the anterolateral is really a lateral portal.
Yeah.
But why do they call it anterolateral? Because there is another one posterior here, so they call it posterolateral. Because there are two laterals, that's why they call this anterolateral. But technically it is lateral. You're just above the greater trochanter. You're 1 centimeter proximal and anterior to the greater trochanter. So it's really a lateral, your lateral portal, okay? The anterior portal, which was initially described, was here, and then they developed some mid-anterior, which is anywhere here. The mid-anterior. So anterior, mid-anterior. And now we've come around this area as the distal anterolateral. Again, it's, I think, being called mid-anterior also. Right, Mark? It's, the namings is not very important, but just if you listen to them, don't get confused. Mid-anterior, distal anterolateral, they're all in this region. This is the proximal anterolateral, we know that. But the mid-anterior is here, 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 similar. There's an overlap of namings. But at least you know now what it is. So your anterolateral is really a lateral portal, the one anterior to the greater trochanter.
But there's one difference that makes happen that the distal anterolateral and the proximal anterolateral is right, it's around the curve or to the distance, equidistance to
But this is...
the mid-anterior, you can actually play medial and lateral a little bit more. You're not really...
There's no specific, this is my surgeon preference. This is what I gathered from seeing someone like Philippon doing the arc, and then I saw someone going, so this is my view of it. You'll find that Mark does it in a different way. He puts it slightly higher, slightly up. There is no real place where you should put this portal here in this rectangle. It could be anywhere here, depending on what you're used to, what you think the pathology will be done. There's no specific place for this one. I told you my trick of doing it, alright? But this is a Philippon technique, this curve, and
A
just...
very nice way of looking at it is just to try to have a mental imagination where you establish this. And then imagine where you're going to go from to the skin, in what direction you're going on to hit your target on your abdomen. And I saw Mark yesterday saying, yes, I'm going to go this way, this is where I go, but perhaps because my muscles are a little bit short, so I'm a little bit proximal.
Yeah.
Actually, so it's a bit of a mental imagination.
Definitely.
I think the important thing, what you have said, you must know where is the kid and what do you want to do. The aim of the distal anterolateral portal is to have an access that makes you more easy to reattach the labrum. But you must consider a lot of things. If it's a very thick leg, you cannot go so distal because then your instrument will not arrive. So you must go more to the anterior portal. But if you go to the anterior portal, you will have problems to reattach the labrum. So you must decide the best option in each patient. And not be so strict with that. Yes, this is the safe area. You can do as many portals as you want. Yeah. He has his portals, I have my own ones, and every of you will have your portals. For example, that is the anterolateral portal that was the first one described by Burman in 1932. And it's the initial portal for nearly everybody. But some guys do 2 centimeters, 2 centimeters. Some other ones, like me, like to go more lateral. So it's not important.
It's valid.
The thing is that you feel comfortable with that.
I think for starting, we give you guidelines, and then later on you, like just in the knee and the shoulder, just have your guidelines. Later on you find you're more comfortable with somewhere than the other. So the last talk in the course, I know you're all excited for the last workshop, is complications. So we've seen, I think, very nice surgeries. However, we must be aware of the complications, and they are there, and they're much different from knee scope. We cannot tell the patient it's keyhole surgery, minimal complications. It's completely different from the knee. I think when we're doing a knee, you rarely have a complication. Even in the shoulder now, very rarely to have a complication. Hip arthroscopy is different. Okay, the complication rate is high, especially early in the learning curve. So when we look at the literature, we will know that this is not true. And once you start your hip scopes, you realize that this is not true. It's completely different. Complications are there, and you must be really well aware of them. So we're going to tell you about them and how to avoid them. Now, when you look initially at the literature, it's between 1.5 and up to 4%. That's not too high. But these guys are doing hundreds or thousands of hip scopes. So these are the experts. These are the top, one of the top 3 or top 3 of the top 10 arthroscopists in the world. So their rates are up to 4%. This is different from a published study who only published the first 73 cases, 7%. So this is much different. So your complications will become diluted the more you do. Your rate goes down. But most of your complications are in the initial learning curve. And there was a study that showed that the complication rate is worse, and you don't feel comfortable until the first 30 cases of hip scopes. After 30, you're much more comfortable. Okay? Of course, above 100, you're becoming at ease, and you know what to do, and you can achieve most of what you want to do. But you're really uncomfortable to 30 cases. So this is normal if that happens with you. But then, just last year, Brian Kelly and Christopher Larson, they did a multi-center study. They wanted to see new numbers. So again, these are high volume centers, not your occasional hip scopes. 1,000 patients, they're overall almost 7%. So the initial low numbers are real experts. Forget about them. So this is a multi-center high flow. So don't be discouraged if your complication is actually much more. Okay? And a very important paper, I think, just came out. It's in the article Ahmed has in the issue, and they compared the complication rate of a surgeon who started in a place by himself, and then they compared the complication rate of his assistant who started under him. And of course, the assistant's complication rate was much less in the same place because he has a supervisor. So it makes a big difference if you're starting with someone who already does it. Then you're lucky. The commonest was lateral cutaneous nerve of the thigh, and that happens from our portals, especially the anterior ones, the anterolateral, distal anterolateral, and the more anterior portals. So it's important that you take care of the skin, just a skin incision, and then you go in with the needles. So 18%, that's the common lateral cutaneous nerve. Luckily, most of them are transient. However, a small percentage may be permanent. Pudendal nerve affection, that was 1% almost. DVT, this is new. Until now, really, I have not been doing any DVT prophylaxis for my hip scopes because I don't do for knee and other things. I give for trauma and arthroplasty. But there is an incidence, so I think if you have any doubt of a patient who is a bit risky, maybe obese, you should consider DVT prophylaxis because it's in the literature now, followed by other pathologies. Now, when I think of complications, I divide them into 3 categories. Okay? Number 1 is traction problems, and that's because these are the commonest, and actually it's the first part of your surgery. Number 2 is things happening during surgery, and number 3 is after the operation. Complications that may happen after the operation. So, traction, again, now on top of the list is the neuropraxis of the nerves, the pudendal, the sciatic, the femoral. This is some of the commonest things happen. Perineal bruising, vascular changes at the ankle, and inability or failure to distract. In Willer series, it was 3%. So So there will be some people that you may not be able to distract, and you have to put that in the plan. It is a complication because you don't know, you haven't done what you plan to do. So you want to keep your traction less than 22.5 kilograms or 50 pounds. And be careful of the position of your traction, and I'll show you why there was a complication with traction position. Most of them are transient, and it's a lucky thing that most of them are transient. You know what happens with pudendal nerve? They get anesthesia around the peroneal injury, and men may get impotence for a few months. This is very dangerous. You have to keep that in mind, and you have to be aware of it. And hopefully everything is transient. And then we have the big nerves, the sciatic and the femoral. That's why we do traction in a slight flexion. It opens the hip, relaxes maybe the femoral a little bit. We have not seen sciatic. I think it's quite rare, the sciatic. We haven't seen it from traction, but mostly I think it may happen from instruments. So femoral nerve has been described by Miller. We have seen also a number of cases here in our unit as femoral nerve. Luckily, all are transient. They all have recovered. By 3 months, they have recovered. And the theory is that we were doing some traction in plantar flexion, but we don't have a final confirmation why they were happening. We were pulling in plantar flexion, and we have a theory that may be causing traction on the nerve, possibly. Because most of these cases did not have a long traction time and did not have any specific difference, something different from the other cases. Now, peroneal bruising, be careful if you have a large peroneal post. It's very important because it's important in the genitalia in men and females. And this case was, I published with Michael Deans. It was one of his cases. After the operation, the foot of a patient was completely cold and paresthetic. The patient actually was discharged, came back after a few days, cold, paresthetic, and they did an MRA and they found that all the vessels had stopped at the level of the ankle joint. So they gave her vasodilators, antiplatelets, and she recovered fully after that. But we have a theory that maybe the boot was too tight, it was constricted too much at the level of the ankle, or that the ankle-foot position has changed. And it's important, when you are doing traction in extension, your leg ankle is about 90 degrees, so that's not a problem. When you are working on the peripheral compartment and you flex the leg, that angle might become very acute. It's important to realize and readjust the ankle to be 90 degrees with the leg. So you don't have a constriction here over the skin that may obstruct your vessels. Okay? So think about the positioning of the foot. It's very important. The traction, you have to be in the OR doing it, the positioning. So traction time, Reynolds, this is other possibilities, but they were excluded. So you want to have a nice, large post. These are now specialized traction tables. So you can have, beside our regular traction, which is like a trauma traction table, there are specialized hip arthroscopy traction table. Very large post, and you have this nice boot that you strap the leg, and then you can pull, you can extend, you can take the boot out to do dynamic testing of the leg, and then come back. Okay, so if you have the delicacy, please buy this. But other people have described doing hip arthroscopy without the classic system that we're talking about. Someone has described the external fixator. A guy in Switzerland named Hassan Sadri. External fixator. So no traction, no post. He just puts pins in the ilium, pins in the shaft, and he extends the hip. Some other people use the bean bag. You know, the bean bag fixes the body, and they pull the leg, no post, and the hip still comes out a lot. Okay? So that really discusses the option of, do we need a lot of lateralization of the post as it is commonly recommended or not? Because these people are not using any post, and the hip still comes out lateral and distal. So these are things from the traction. Then we have complications during the operation that you can do. Cartilage labral damage, very common, but it's underreported. You don't report that you scuffed the cartilage, but it happens very commonly. We don't know how much it does have a clinical effect, but it is there. Lateral cutaneous, inadequate surgery, broken instruments, and fluid extravasation. So you've seen the central compartment. You've seen how we do a trial reduction. Mark did that and Ahmed did that this morning. They did a trial make sure that your reduction is fine. They went away from the labrum, did the wire next to the head, or you can do the peripheral first technique, which I showed you, which protects the labrum, and be generous with your capsulotomy when you're in the central compartment to allow your instruments to move freely. Now the resection, up to 70 to 90% of revision cases are because of under resection. So that's the commonest thing. When you're starting, you see a small view, you take a small piece of bone out, but you haven't really seen the global view. So you must see around the curve, as I've explained, and that affects, that makes sure you've done the job, and of course check with the CR. On the other hand, you can take too much off the head. Now this case actually is one of the nurses in a hospital I work with in Cairo, and she had a hip scope. Okay? Now I wasn't sure why she was still complaining after the hip scope, but you can see that. Part of the femoral head is gone. It was resected. So we have to be careful, you have to know where you're resecting, and if you're working in flexion, it's different than if you're working in extension. Okay? So probably the surgeon applied the principle, same angles we're using, but he was in extension rather than flexion. So this head, part of the head was excised. That's why there is complaining, and you can't really do much for this patient. So under resection, of course, is much safer than over resection.
So this is surgery.
This is post-surgery, post-operative. Post-operative still complaining. So you can see part of the cam is still there, and then part of the head is missing.
دكتور حاتم حتى لو احنا شلنا بارت اوف ذا هيد عشان نطلب هنا فين of something.
But yeah, you wouldn't go into this patient again. It's a problem.
ده the operation was not done for
But this is a weight-bearing part, so
Why this side and not the other side?
these are sequential cuts.
The Japan here is still there. So
Yeah.
Was this the side that break the bone?
No, it's the same side, it's the right side. It's the right side operated and part excised.
And the cam is in the left side.
No, cam was here. Maybe she has a little bit here, but mainly the cam was there.
I mean, this part is a non-repair. Okay, it's a little bit more intriguing. I think what Ahmed is
This causes pain.
is that perhaps now the edge and the remaining of the cam, she's still thinking.
Possible.
Understand
Possible.
and go back in.
Don't touch the patient. Okay, now don't forget broken instruments. You have to be very careful with your wire. You will do that in the workshop. You will introduce your wire, introduce your cannulated guide over it. Make sure that you see the tip of the wire while you're introducing the guide. This is the way to prevent that the wire goes in, gets bent, and gets broken while you're going in. And it's happened a lot to people and surgeons, therefore they recommend that. The other thing is, as you saw, is a broken microfracture instrument. This is my resident, he broke my instrument and we had to fish out the extra piece of metal. Okay? So it changed from a microfracture to a loose body removal. Now fluid extravasation is important. It has been reported, especially when you do a lot of capsulotomy, high pressure on the pump. It has been described as abdominal compartment syndrome. The patient starts usually to go into bradycardia, hypothermia, and one patient went into arrest. In the literature, he didn't die, but he went into cardiac arrest because of the abdominal compartment syndrome. So this is something to keep in mind, especially if you're doing psoas release. So if you have a procedure that will include psoas release, keep the psoas release till the end. That prevents the fluid extravasating early. Last thing is the post-operative. So neck femur resection. It's safe until 30% of the neck. Okay? So we want to avoid more than that. Dislocations are becoming more common. So as you saw what Mark did yesterday, if you do the T capsulotomy, it's important to close the longitudinal part of the T to give that patient the stability back. Be careful of patients which have a low center edge angle, such as dysplastic patients, and then you excise more bone, they become unstable. Heterotopic ossification, we prevent that. We routinely give Voltaren 75 BD for 2 weeks after the operation. This prevents heterotopic ossification, and of course we give something anti-gastritis with it too. Adhesions, you've heard how Hassan's talk about the post-operative. It's important. It is an important part in the result. because sometimes patients start complaining again after an initial phase of improvement, and that's about adhesions in the hip. So we have to start range of motion very early. Lastly is DVT and infection, and you've heard how to prevent it. So the recommendations are, for the traction, use a large post to avoid the perineal bruising. Foot padding and position is very important. You have to supervise that yourself. Less than 2 hours, less than 50 pounds or 22.5 kilograms. I personally recommend the peripheral compartment. Do your good capsulotomy when you go into the central. Check your resection if you have the C-arm. Definitely I would advise that in the beginning. And don't forget your topic ossification and DVT prophylaxis. And early range of motion, so that starts next day. You can put the patient on a stationary bike on the next day. It's a very good exercise. It gets the hip moving, and you can do it very lightly, and it's a controlled concentric exercise. Thank you very much. So, مسار تجيبهم وخرجوا ليه؟ جيب الناس؟ أحمد هيقول لنا talk بس 1 minute. He'll show an interesting case he saw برضه عشان عاوز ياخد رأينا فيها, and then we're going to say thank you before we move on to the workshop. We have very good time for the workshop. مفيش قلق يعني, عندنا ساعة ونص مرتاحين. أحمد will show us just an interesting case.